spotted anything today or tomorrow. So, we talked a little bit about coagulation earlier, and we come back to that later, so it is a big topic. I do like to ask questions on it. It's nice to be able to understand it fully, but now we're going to talk about sexually transmitted diseases. Or sexually transmitted infections. Now, of course, the most common that you come across in clinical practice are chlamydia. Occasionally you'll come across gonorrhea. There's a certain prevalence of HIV around the country, higher in London, Brighton, some of the South Coast areas associated with areas of high intravenous drug use and differing areas of sexual behavior and preference. But although chlamydia and gonorrhea are the most common, that doesn't necessarily mean that it's the most common question that you'll come across in the exam. And of course, you should know how to make the diagnosis of chlamydia and the diagnosis of gonorrhea, but the ones that tend to come up are these strange combinations of penile ulcers or genital ulcers and lymphadenopathy. And it partly comes down to the resurgence that we had in syphilis. There was a big resurgence of syphilis at the end of the 80s, the beginning of the 90s, as there was a relaxation of the use of condoms after the scare of HIV and AIDS at the beginning of the 80s. And again, we're seeing another resurgence over the last 5 of syphilis as well. So I wouldn't be surprised if these ulcery type questions come up in your exams as well. Now, we'll start with syphilis there. Syphilis had a natural course and process. You started off with a painless chancre, which is an ulcer that wasn't uncomfortable but looked pretty nasty. People would get one of these, they would have a look at it and think that's really nasty, I'll go and see the doctor, I'm too embarrassed. After a few weeks they went away and they were quite happy with the fact that it went away. Then people would have secondary syphilis. And in secondary syphilis, they would then get rash, palms and soles would be included. You would sometimes get condylomata lata, which are accumulation of skin taggy type things either around the anus or around the genitalia. Sometimes they could appear elsewhere depending on where you had exposure. But condylomata lata and a rash, including the palms and soles, would occur in secondary syphilis. There would often be a latent period then, but when studies were done on how many people went through the latent phase and ended up with tertiary syphilis, which is where you get the gammata, these collections of highly syphilitic infected tissue accumulations that can occur in the heart, can occur anywhere on bone, on soft tissue. Those are called gammata. Actually, about 50% of people, if left untreated, ended up with tertiary syphilis. Sadly, this again was reconfirmed from the 50s through to the 80s when there was the Tuskegee experiments that you may have heard of in America, where they prevented Afro-Caribbean populations in the south of America from receiving treatment for their syphilis, purely to observe the progress of syphilis again. And there was a public apology by President Clinton, leaving thousands of people without syphilis, diagnosed with syphilis, and prevented them from getting treatment in order to redocument the disease at autopsy. So it was a horrible, and understandably where a lot of the suspicion from the black Afro-Caribbean population in America of the medical profession was from the Tuskegee experiments. So we've got the natural process of the disease from primary syphilis through secondary syphilis. This is latent period, which can last anywhere up to 30 years, and then these gammata. Now, the most feared complications of syphilis is these gammata occurring in the heart and the big blood vessels, and they can also occur in the brain as well. And that cardiovascular or neurological is sometimes termed quaternary syphilis, where you've got gammata, but it's in places that are really bad. And cardiovascular, the most feared of them all. So there's primary, secondary, tertiary, and if you would like to term it, quaternary syphilis. Depending upon the stage of syphilis, you're going to treat them with penicillin for any one of a different length of period. So you've got 1 week of treatment, 2 weeks of treatment, or 3 weeks of treatment. It's as simple as that. And those people with primary syphilis, they only get 1 week of treatment. Secondary and tertiary get 2 weeks of treatment. And quaternary, which is CNS or cardiovascular syphilis, those people get 3 weeks of treatment. Now, in some books and in some places, they sometimes treat the CNS for only 2 weeks, but in CNS disease, they give IV penicillin, and the penicillin that's given is procaine penicillin. Can also be given IM as well, but you can give procaine penicillin IV, orally, IV or subcut. And most places they end up giving subcut. But it's procaine penicillin. This is the most important. A week for primary syphilis, 2 weeks for secondary and tertiary, and 3 weeks for quaternary syphilis. But the bit, if you were to take away anything, is cardiovascular, very bad, neurological, IV therapy, and the drug of choice is procaine penicillin. But what they will love to ask you questions about are all of these, these TPHA, RPR, VDRL questions about syphilis. And a nice little trick to work out is whether the test, all you need to know, look for in the test title, is whether it has T in the title. If it has T in the title, it is a treponemal test. What does that really mean? All it means is that once you've had syphilis, that test remains positive for the rest of your life. If it doesn't have T in the title, then it's a non-treponemal test. What does that mean? That means that if you treat the syphilis and you've cured the syphilis, given 6 months or so, the test goes back to being negative. So now we've got 2 good tests. We've got one test to be able to tell whether somebody's ever had syphilis, and we've got another test that tells whether the syphilis has gone away after treatment. So that's fabulous. We can do a treatment of syphilis. We can then test them again in a year's time, and we can see whether all of that has returned back to normal. So actually, why do we need the treponemal test at all? Surely the non-treponemal test, that's the investigation of choice, because do we really care whether they had syphilis 3 or 4 years ago or not? It doesn't really make any difference. All we need to know is whether they've got syphilis now, and then maybe later whether that syphilis has been cured. Well, there's another problem with non-treponemal tests. That is during the latent phase, between when they have their primary, which goes on to secondary, and then they have this long latent phase before they pop up with tertiary syphilis years later. During this latent phase, the amount of the treponemal load is so low, your non-treponemal test can go back to normal. So during the latent phase, non-treponemal can become negative. Not always, but a good chunk of the time they'll go back to normal. So in this case, if somebody's given a history, they've described primary syphilis and then they've described tertiary syphilis when they were living over in South America, and then they've come back 3 years later and they were just passing in history, and you do a VDRL, has it got T in? No, it hasn't got T, therefore it's a non-treponemal test, and your VDRL comes back negative. Actually, what might be worth doing is a treponemal test. And if that treponemal test is positive, and the person's given a good history of having had syphilis a few years ago, maybe he's in the latent phase at the moment, and we ought to give a course of treatment. We've got nothing to lose. Procaine penicillin, we hand out amoxicillin like it's Smarties. We hand out doxycycline like it's Smarties, giving somebody a treatment for a good history of syphilis with a positive treponemal test, but a negative non-treponemal test. You haven't really lost out anything, have you? Now, there are 3 conditions that have ulcers on the genitalia that have slightly different characters but are very similar. So they like to ask questions to see whether you've done your reading. They probably realise that you're going to know about syphilis and about the progression of disease. But what about if we throw something else with an ulcer on the genitals, painful or painless, and a couple of other features? Can you make the diagnosis? And what I like to call the Holy Trinity, or the nasty 3, are chancroid, lymphogranuloma venereum, and granuloma inguinale. Have you come across these when you've been doing questions at all? No? No. It does. It comes up a lot. That's it. It's always, and you can't remember which ones are painful and which ones are supposed to be painless. You know that syphilis is painless, but as soon as you start moving into painful ulcers and they start mentioning these three on the list, then you're probably going to get the question wrong. But bank on the fact that if the question comes out, you only need to know a few facts in order to be able to get the question right. So this is about the ulcer, and this is about the lymph nodes. And this is all about pain. Is the ulcer painful? Are the lymph nodes painful? Now, chancroid, nice one to remember, they're both painful. Sorry, I'll do a tick, otherwise it'll get really complicated. So that's painful, and the lymph nodes are painful. Lymphogranuloma venereum, the lymph nodes are painful. And granuloma inguinale, neither are painful. So now you've got three conditions that give you painless ulcers: lymphogranuloma venereum, granuloma inguinale, and syphilis. Three conditions that give you chancroid, both painful. Lymphogranuloma venereum, painful lymph nodes. Now, there are a couple of extra special features, and then we're almost done with the holy trinity of nasty ulcers. Chancroid. In chancroid, you can get a suppurating lymphadenopathy. You get a little sinus that appears from the lymph node to the surface of the skin, and you get this pussy, nasty, cheesy substance that comes out the lymph node. Of course, as soon as they start to talk about pussy, nasty, cheesy stuff coming out of the lymph node, you're going to think about tuberculosis. That's what you're going to think. But if they've talked about an ulcer, and they've also talked about lymph nodes, then you're into the holy trinity, and chancroid has got a suppurating lymphadenopathy. It's usually inguinal, so it's usually what you do is you get lymph nodes round about the groin region, and you get your ulcer on your genitals, and it's usually the ones that are inguinal that end up suppurating. It's closest to lymphatic drainage from where the nasty infection is. So you don't get them up so much on your neck or anywhere else, but it's usually lower body. Several. What do you mean as far as clinical badness? Yeah. No, that's generally bad. I wouldn't not go to my GP if it was one, but if it was three, then I'd be definitely down to A&E. Lymphogranuloma venereum. This is starting to pop up here and now. I saw one of these when I was doing a gastro-reg job here, where a guy came. He had gone on holiday to Thailand with his wife. It was a business trip. Came down. His wife was there all of the time. He had never got up to any badness, and he came back with a syndrome that looked very much like ulcerative colitis. And we went through the whole ulcerative colitis thing, and he went, and I was sitting there thinking, this is not quite right. And then it popped into my head, and he had lymphogranuloma venereum, and this gives you a colitis. Very satisfying. So those are the special features. There is a little special feature on histology for granuloma inguinale, and those are Donovan bodies. For the life of me, I tried to link Jason Donovan somehow with granuloma inguinale, and I didn't have much luck. Now, these are treated with tetracyclines. So you can treat them with doxycycline, oral tetracycline, anything with cycline in the name. But chancroid is treated with cotrimoxazole. Where have you seen cotrimoxazole before? PCP, yeah. And then those people who are not responding to cotrimoxazole with PCP, then you can use IV pentamidine. So just making a vertical string, and we'll try and come back to a little bit of HIV stuff later. But cotrimoxazole. And that's everything, really, that you need to know about those. It'd be nice to talk about the organisms that we'll talk about in just a minute, and there's a chancroid one that keeps on coming up, the organism again and again, but we'll come back to that shortly. Now, I'm not going to forget about chlamydia and gonorrhea. Now, when it comes to diagnosing a sexually transmitted diseases, of course, the gold standard test is going to be a urethral swab, really, to see whether you can get that nastiness and then send it off for analysis. Or in a woman, it's going to be an endocervical swab. So those are going to be the gold standards. Now, in gonorrhea, you're going to go for the gold standard. And gold standard is going to be for a man, a urethral swab, and for a woman, an endocervical swab. Now, sadly for women, but fortunately for men, if men pick up chlamydia, a urine test is just as good as a urethral swab in chlamydia. So you can get away, not with women. With women, it's okay. You can take a urine sample, and you'll get sensitivity-wise, you'll pick up most of the cases, but it's nowhere near as good as an endocervical swab with women. But for a guy, men are lucky. For chlamydia, you can get away with just providing a urine sample. So gonorrhea, do the gold standards. Chlamydia, lucky men.
Is that because it's less sensitive? The urethral swab is less sensitive in a man?
No, it's because the urine is just as good as the urethral swab, and the reason being is that it's not just the long distance, it's where the path of your sexually transmitted disease is going to propagate. So for a guy, once the deed has been done, the bacteria is deposited in the urethra, and that's where things are going to go. For a woman, where the badness is deposited is in the vagina. So the urethra isn't contiguous with the sexual canal with a man, whereas it with a woman, but it is contiguous with a man. So semen passes down the urethra, fluid gets forced back up the urethra. So actually, a urine sample for a man is very, very good because urine is going to go past the infected tissue, whereas in a woman, their urine, actually their urethra may have been unaffected by the sexual disease itself. That's why. Now gonorrhea, because it's a sneaky little sucker, it'll stand to the walls, and then when you pee, you might not be able to get the yield that you need. You might not be able to get the sample size that you need in order to be able to get a positive test. So urethral swab is what you're going to do. Also, gonorrhea, increasing cases of pharyngeal gonorrhea these days. You have to do a swab at the back of the throat in order to be exactly how my mother asked me that this would happen when she came and sat at the back one time, that people get pharyngeal gonorrhea, and that was a very uncomfortable afternoon meal. Now, for chlamydia. The treatment for chlamydia is pretty much the treatment for these diseases. It's doxycycline. You give a week's worth of doxycycline. Uh, 152. Now, it may be that the person that comes into your clinic and they've got a diagnosis of chlamydia, you don't really trust that when you send them back home they're going to finish their course of doxycycline and they're going to go around, be a bit of a tomcat, and end up propagating this illness elsewhere. And you want to be able to give them a single dose of something so that you know that once they've taken that tablet and you've seen it drinking it with a glass, when they walk out they're going to have a cure. And you can do that with chlamydia, and that is with azithromycin. There was a military doctor not too many years ago that was struck off when his also medical wife noticed that there was a strange taste to her food and found a packet of azithromycin that he had crushed up into her food because he was trying to treat her chlamydia without her finding out that he had given it to her. So that's a single dose, one-off dose. So if you're pregnant, you can also use azithromycin over using doxycycline. You could also just use oral erythromycin either. But azithromycin is a single dose. Gonorrhea. If you found out that your husband has given you gonorrhea, you'd want to fix him, in the veterinary sense of having him fixed. And the treatment is cefixime. That's about now, cefixime. So one-off dose of oral cefixime. Or you can give IM ceftriaxone. Why would you give somebody IM ceftriaxone in prison? They usually treat gonorrhea with IM ceftriaxone because patients, prisoners often store the medication inside their mouth, spit it out again, suspicion of the medical profession. So in prisons they usually use IM ceftriaxone. Also, if you were having to treat pharyngeal gonorrhea, you would also use IM ceftriaxone as well. Again, the finer points of these you don't really need to know. The point that you need to take away is it's a cephalosporin that you treat gonorrhea with, and that's a one-off dose. Chlamydia, it's doxycycline unless you use a one-off dose of azithromycin, and this is what you would do in pregnancy. So we know the treatment of lymphogranuloma venereum and inguinala is tetracycline, usually doxy, cotrimoxazole, cephalosporin, one-off dose of cephalosporin, one-off dose of azithromycin, or a week's dose of doxycycline. We know with syphilis, if you've got primary, then you give a week, secondary or tertiary, then you give 2 weeks. If you get one of the bad places like CNS or CVS, cardiovascular system, then you would give it for 3 weeks. And also, if it was neurological, give it IV. Again, it's going to be the drug type that they ask you for, they won't ask you for drug dose, frequently not even a length of time. What they're looking for is, do you know, when it comes to infectious diseases, what you treat a chest infection with, what you're going to treat somebody with chlamydia. These are going to be things that you see every day. So they'll either ask you questions about diseases that you see every day, or they'll ask you questions about things that have obvious distinguishing features, or they'll ask you things about what you could kill somebody with if you don't know about. And then some stuff to pack out the space. So, gonorrhea, how do you make the diagnosis? What do? You take a swab. And you take the swab and then you try and culture that on Thayer Martin media. You recognise Thayer Martin? Chlamydia, you send it off and you do the nucleic acid amplification tests. That's test. Syphilis, well, you had treponemal and non-treponemal tests, but if you find a really old school place, they'll still do dark ground microscopy, where they take it and they look for corkscrew organisms. And these are slightly motile. It's very hard to do, not many places do it anymore. You also need to find an infected, nasty piece of tissue in order to be able to swab. So because it's so difficult and these tests are so good, dark ground microscopy they hardly ever do anymore. But it's worth knowing about. Moving quickly on to classification of bacteria. Now, it's not too infrequent that they talk about a bacteria and they ask you what type of bacteria that is. They do the same with antibiotics, and then they ask you what category it fits in. Does it affect the cell wall? Does it affect protein synthesis? Does it affect? And there is an easy way that I think there is to remember this, and you may have come across a very similar mechanism. But things are broken into cocci and bacilli. Then you have gram-positive and gram-negative. And positive and gram-negative. So in gram-positive cocci, those are staph and strep. In negative, gram-negative cocci, I've got M and N. Neisseria. Sorry, I'll do it back to front. Neisseria and Moraxella. So Moraxella is Moraxella catarrhalis. It gives you infections in people who've got chronic obstructive pulmonary disease and bronchiectasis. Neisseria infections are Neisseria, that's gonorrhea, and meningitides. Causes meningitis and gonorrhea. Bacilli A, B, C, D, and L. There's actinomyces. Now it's got myces in, so some people were saying, well, that sounds like a fungus to me. Well, they've just renamed it actinobacilli. They used to think it was a fungus, but actually it's a bacteria. Bacillus, and that's Bacillus cereus. That's found in cereals. The reason that that's of interest is because it's the substance. You find it in rice, reheated rice. Chinese restaurant question. Somebody comes back and within 5 or 6 hours, they're vomiting like it's no tomorrow. It is the bacteria that causes the fastest onset of vomiting gastroenteritis of any of the bacteria. So that's why it's important to know. Bacillus anthracis, anthrax. Clostridium. The one that you probably come across the most is difficile. And that's because difficile is rarely difficult to culture that. We can look at the toxin, but doing the culture of it is very, very difficult. Clostridium perfringens. Nasty one that causes skin and soft tissue infections. Clostridium, what's the other one? My mind's gone blank. Oh, yeah. tetani, so tetanus infections. That's the one that somebody comes in and you have to give, you can give a tetanus shot for, but you can also give antibodies against the tetanus toxin as well. And botulinum. That's botulism. D for diphtheria. That gives you a coating on the back of your throat that you kind of try and move the membrane and it tears and then it bleeds a lot. It can also give you cardiac arrhythmias. So that's diphtheria. And then L for listeria. Listeria, why is it important? You are more susceptible to it when you are immunosuppressed, most commonly when people are pregnant and they're told don't eat any soft cheeses because it'll have listeria in, because you can get listeriosis. You can get infection of the fetus with listeria. You can also be more prone to listeria meningitis when you're pregnant. Also the elderly are sometimes affected by listeria meningitis. And in actual fact, it's common enough to have an antibiotic policy specifically for listeria meningitis. And that's why somebody comes in with a meningitic looking picture. You do your CT, then your lumbar puncture. Once you've taken a lumbar puncture, you look at it under a microscope and you ask for a gram stain. And if the gram stain says I've got a gram-negative cocci there, you say, okay, well, gram-negative cocci is probably Neisseria meningitidis that I've got as meningitis. It could also actually be in reality gonococcus, because gonorrheal meningitis is reasonably rare, but not vanishingly rare. But if they come and said, actually, you've got a gram-positive bacilli in there, your money has to be on listeria, and ampicillin must be included. There's a little sheet specifically on intracranial infections in your handbook that we don't have time to cover during the course, but it's only 2 sides. You can read through it pretty quickly. And then this at the bottom, this is everything else. So if I said that somebody had a strep pneumoniae, what is it if it's strep pneumoniae? Gram-positive cocci. If somebody had listeria, gram-positive bacilli. If somebody had Moraxella, gram-negative cocci. If somebody had E. coli, it's not on this list here, so it goes down here. Gram-negative bacilli. And then so you run through that in your head. What about H-Pylori? Where's H-Pylori? It's a gram-negative bacilli. So you can then start being a little bit creative when somebody comes back and says, what type of organism is that? What type of cover do I need for my antibiotics? And by knowing that list, it's very, very helpful. And especially on ITU when it comes back and it's grown a gram-positive bacilli, and you're the only person who can come up with a list of all of the things it could possibly be. It's quite satisfying, and it's not a very long list to learn either. Stenotrophomonas is what? Gram-negative bacilli. You see, you can play the game all day. Covered everything. Okay, just like you to turn to the back page, right at the bottom on the right-hand side, for the most common causes of septic arthritis. Most common cause overall is Staph aureus. Gonococcal. Now, gonococcus can cause both a reactive arthritis, usually called Reiter's disease or Reiter's syndrome, where you had urethritis, conjunctivitis, and aseptic arthritis, where you just found inflammatory mediators. But you can actually get a septic arthritis from gonorrhea actually in the joint itself. And it's now starting to become the leading cause of septic arthritis in sexually active adults. That's not with the same person for 25 years, it's sexually active. Haemophilus influenza is the most commonest cause in under 3s who haven't been inoculated. And we have big swathes of children coming through who haven't been inoculated because their parents were worried that they might make them autistic. Now, chlamydia. Last thing before we head and do the question and the take-home points. What is the concern about chlamydia? Well, chlamydia, the concern really is pelvic inflammatory disease. We contract trace people because if we find somebody with chlamydia, if they name somebody, on average, 60% of those people, they stand a 60% likelihood, each person who's named, to be positive for chlamydia. So then they then have contacts and they will stand a 60% chance if they're positive of also contracting chlamydia. When you contract chlamydia, you stand about a 33%, it's between 10 and 40 in the literature, about a third chance of getting an episode of pelvic inflammatory disease. And for each episode of pelvic inflammatory disease, you stand about a 10 to 20% chance of infertility from that episode. So there is a huge burden of infertility that falls down to the spread of chlamydia, and it's incredibly common. Now, we are going to want to follow some people up. So they name these people, they come in, even though we've contact traced them and we test them, we treat them before we've even got the results back in the vast majority of people. You just treat them, because we hand out amoxicillin like Smarties, we hand out. So when we've got a 60% chance, somebody with a 60% chance of having a sexually transmitted disease, what's the risk of giving them a one-off dose of azithromycin or sending them home with a week's course of doxycycline? There's nothing, the elderly are doxycyclined heavily. We are going to want to follow some of these people up to see whether they're cured. And who do we follow up? We follow up those people who come back and say, I've still got symptoms. If they've still got symptoms, what's the problem? The problem is they've got another sexually transmitted disease. So that's why we test them. Once you've found one sexually transmitted disease, start looking for all of the rest that they're likely to have. So people who carry on complaining of symptoms. To those people who are pregnant when they present with their sexually transmitted disease, because we want to make absolutely sure that this person is done and dusted with that, because you've got an innocent little fetus that has to pass down a potentially infected canal. We've got to make sure. So these are the people that we follow, the pregnant. And those people, that was a swab, by the way, those people with pharyngeal gonorrhea, we have to follow up and test for a cure. So those are the three people.
Does that have repercussions like increased cancer?
I don't know. There may be some data on it. But what I would probably be more concerned about is an episode of potentially immunosuppression and then respiratory tract infections that could be complicated. That would then be quite nasty. That's why I would imagine it's just part of the respiratory tract. But I don't know for sure. I'd have to look that up. So the three categories of test for cure. Oh yeah. Chancroid, these are the three different, I'll just write the list out again. Chancroid, lymphogranuloma venereum, and granuloma inguinale, the organisms that are associated with them. Chancroid is Haemophilus ducreyi. Lymphogranuloma venereum, L1 to 3. And granuloma inguinale is Klebsiella granulomatous. So I think that's, I've forgotten now. It is chlamydia. L1 to 3. Now this is the one that keeps on coming up time and time again, so if you were to put your money on one of them coming up, it's going to be Haemophilus ducreyi. The reason why is granuloma, this Klebsiella granulomatous, that's recently been renamed in the last about 5 years, so they won't bring that up. It's going to be this one that comes up, if any of them were. So we go to the take-home points. In chancroid infection, both the ulcer and the lymphadenopathy is painful. You also get that nasty suppurating lymphadenopathy as well. VDRL becomes negative following treatment for syphilis. VDRL hasn't got a T in it, so it's a non-treponemal test. Same with RPR. It hasn't got a T in, so it becomes negative following treatment for syphilis. And sometimes in the latent stage of syphilis. But treponemal tests, so with anything with a T in it, like TPHA, remain positive for life. Concerning chlamydia diagnosis, urine sample is as good as urethral swab in men, but endocervical swab is most sensitive for women. Chlamydia is treated with doxycycline for 1 week, whereas gonorrhea is treated with a one-off dose of oral cefixime or IM ceftriaxone. But you can also treat chlamydia with a one-off dose of azithromycin. Just don't crush it into your partner's food. Gonorrhea is diagnosed by swab and culture on Thayer-Martin media. Chlamydia is diagnosed using the NAT, nucleic acid amplification test. Syphilis is treated with procaine penicillin, or you can use tetracycline and penologic. If you get a sexually transmitted disease, probably the take-home point is that if you can't remember anything and you go into shock, that if you pick tetracyclines, you're probably going to get it right. But if you can learn it, it's worth doing. So we go for the question. Thayer Martin, a 24-year-old man, attends his GP complaining of discomfort when he passes urine. He has an extensive travelling history and admits to high-risk sexual behaviour undertaken with multiple male and female partners. He currently has a girlfriend who is 4 months pregnant. Concerning this man's past history, choose the best option from the following. So we'll go with Nikki for the first one, see what you think. A painless penile ulcer with painless lymphadenopathy would be consistent with Haemophilus ducreyi causing chancroid. They're both painful. So the bit that's correct is Haemophilus ducreyi does cause chancroid, but both the ulcer and the lymphadenopathy is painful with the suppuration that goes along with it. A VDRL test would be better than TPHA at picking up latent syphilis. What do you think about that, Karen? If you had to pick a test that picks up latent syphilis, would you pick a treponemal test or a non-treponemal test?
It's non-treponemal.
So a VDRL is non-treponemal, but which is better at picking up latent syphilis, a treponemal or non-treponemal?
Treponemal.
Treponemal is. And VDRL, as you said, is non-treponemal. So no, that one's wrong. If he is found to have gonorrhea, which is a gram-negative cocci, a 7-day course of doxycycline is a preferred treatment. What do you reckon, Gemma? We've gone through so many antibiotics by now. But if he's got gonorrhea, do you want to treat it with doxycycline? You want to fix him. If you find out that he's got gonorrhea. No, it's ceftriaxone or cefixime. So yes, it's a cephalosporin. If he is found to have chlamydia, his girlfriend should be treated automatically, even before NAT results are available. Sonia, would you treat a contact tracing before you got the results back? Yes. Yeah, so you may as well treat him anyway. She must also be retested following therapy. Should she be retested following therapy?
Yes, because she's pregnant.
Yeah, so she fits into those 1 of 3 people category. Rash on the palms and soles is characteristic of primary syphilis and should be treated with 21 days of procaine penicillin. What do you think about that, Hannah?
I think no, because rash is secondary.
Yeah, that's right.
And if it was that, you treat it with 2 weeks.
If it was secondary, 2 weeks, yeah, and primary you would treat for how long?
1.
1 week, yeah. Okay, any questions?
I was wondering what the infertility risk is, just to gauge some sort of statistic in my head for women who contract chlamydia.
The infertility risk.
Yeah.
You're probably looking at about 30% get pelvic inflammatory disease. And even if you were really pessimistic and said 30% of those, you're looking at 10% per contraction of chlamydia, but probably it's more likely to, more like 3%, I would say, per episode. other questions? Okay, if you'd like to turn to page 11. We're going to go straight for the question on this and read it through. A woman in her late 30s attends her GP for an insurance medical. It comes to light that she had ongoing symptoms of dyspepsia. She is otherwise well, but complains that these symptoms have been present for the last 3 or 4 years. Although her job is stressful and her diet is not as good as it should be, she becomes increasingly concerned that her symptoms represent cancer rather than something benign. Which of the following statements is most accurate? Okay. These questions all boil down to what do you do with people with symptoms of dyspepsia? And because gastroenterology clinics and GP clinics are filled with people coming in complaining about dyspepsia, the NICE have released some really tight guidelines about what you should do with them. And you should know these guidelines, firstly, because it will help you with your exam, and secondarily, it helps you deal with these complaints of people complaining of dyspepsia very, very easily. And you want to deal it in a way that you can't really be criticised, because what you're worried about is there's something bad and nasty going on, but you know that the vast majority of people, there'll be nothing wrong with them. So we start off with, what can somebody tell you that means that you have to order an endoscopy and nobody can argue with your request? And those are red flag symptoms, dyspepsia plus a red flag symptom. And I like to think of them as starting at the top. Is either you have recurrent vomiting, food keeps on coming up, difficulty swallowing, an epigastric mass when you press in the epigastrium, that can't be a good thing, weight loss, or iron deficiency anemia. All of those things in combination with dyspepsia, it doesn't really matter what the age is of the person, that person has to have an endoscopy. So when somebody comes in and complains of dyspepsia in the gastroenterology clinic, I will go through and I ask them those list of 5 questions very quickly. Do you have difficulty swallowing? Do you have recurrent vomiting? Do you have weight loss? Do you have, do I feel for an epigastric mass? And I do blood tests looking for a microcytic anemia. If I find a microcytic anemia or even just anemia, I'll do iron studies. If there are anemia with low iron, they have an iron deficiency anemia, therefore I'll do an endoscopy and I don't even have to argue any further. If that's negative, then I've done the investigation that's needed. I can give the person some proton pump inhibitors and send them back to their GP. It's a very easy job to do. So red flag, have to scope. And those are in the box at the top of the, just underneath take-home points, alarm symptoms. But there are other criteria that if somebody is over 55 and they don't have a red flag symptoms, there's things that they can come up and complain to me about that I'm then going to have to say, okay, well, we're going to have to go in now and do an endoscopy. But if they're under the age of 55 and they haven't got a red flag symptom, I'm done and dusted. I can do one of 2 things. I can give them a month's worth of proton pump inhibitors and send them away, or I can do a test and treat protocol for H-Pylori. Which one of those 2 things shall I do? Well, NICE hasn't stipulated which ones are those things that they think I should do. So I can flick a coin, and depending on which side the coin lands on, I can decide whether I'm going to give them 1 month's proton pump or I'm going to do a test and treat. If my hospital is short on money, then I'll just tell the GP to write out 1 month's of proton pump, and there's no criticism that could occur based upon that management plan. But if they're over 55, if they say that their symptoms are recent, all my life I've been fine up until the age of 65, and for the last 6 weeks I've just had this really burning pain, this pain of dyspepsia, and that's not been right. Well, if they've never had dyspepsia all of their life until they're over 55, until they're 65, 70, there's something fishy going on, something has changed. If they're 25 and they're going out in the lash every night and they like a curry and they complain of dyspepsia, I'm not as interested as somebody who's 65 who's saying this is different, something's changed. So the symptoms are recent, persistent, and what they mean by that is if somebody comes in and says, I've got a little bit of dyspepsia, but actually it only lasted for an hour and it happened last Tuesday and I've been fine since then there's no worth endoscoping them based upon the fact that they've had, an hour of dyspepsia. That's probably not an issue. So it's got to be persistent. It's got to carry on being a problem. If it comes and it goes away and everything's fine, then you leave well alone. Persistent. And if it's recurrent, so if they said, I keep on getting this, every Tuesday, Wednesday, Thursday, I get it for a few days and it keeps on coming back and it's a recurrent problem, then also. So it's recent, persistent and reoccurrent with over the age of 55, then you've bought yourself a scope. Is that clear? Now quickly moving on to H-Pylori, there's a number of different tests that you can do for H-Pylori. Now the one that NICE says that you should do if you're wanting to do a test and treat is a urea breath test. Sometimes incorrectly called a urease breath test, but it's a urea breath test. You take labeled carbon as part of urea. The H-Pylori has urease, which can break down urea into its carbon dioxide component and elsewise. You then end up exhaling it. So you take your little drink, you wait 20 minutes, half an hour, you then breathe out, and depending upon the type of urea they've used, they can measure that in one of two different ways. The long and the short is that you take a little drink of something and then you breathe into a machine and the machine says whether you've got H-Pylori or not. So that's a urease breath test. Some hospitals haven't got the equipment to do them, so they do kind of cheat and do other ones. So we start off with H-Pylori. You've got the urea breath. You can also do the fecal antigen. This hospital here does fecal antigen for it. Take a little sample of your poo, and they look for H-Pylori antigens in the poo, and it's quite easy to do. You can send somebody away with a pot, and they can return some poo. People don't like doing it. You can also do a serological test, take a blood test, and look for antibodies against H-Pylori. Now, after 6 months of treatment, those go back to normal. But you could have had an antibiotic course, have cured it, but still have positive serology for that next 6 months. Our last one is on endoscopy. You can take a sample of juices, take a little biopsy from there, and you can either drop it onto a pregnancy test-like thing and look for the 2 bands, which is the CLO test. So this is post OGD. You can either do a CLO test. Now that's Campylobacter-like organism test. That's because when they first found H. pylori, it looked like Campylobacter, so they called it Campylobacter-like organism. That's not to be mixed up with columnar-lined esophagus, which is Barrett's esophagus. So you often see CLO, and you can see it in 2 different places. CLO as part of the test, and CLO as part of columnar-lined esophagus, which just means Barrett's esophagus. And you can also do microscopy, looking for that gram-negative organism that is spiral-shaped. And we had another spiral-shaped organism on dark ground microscopy, dark field microscopy, which was a syphilitic. So microscopy, and you can also culture it. But all of these you can only do if you've had an OGD. Otherwise it's urea breath test, fecal antigen, or serology. But the serology stays positive after treatment. Have I? Yeah. Okay. Yes, nicely spotted. I put resistant, current, and unexplained. That's about duration. It's got to be there for a little while. Can't just be a one-off episode. And then you're right, there's unexplained. So if somebody had a big chili curry and then they had dyspepsia afterwards, then you probably wouldn't be that interested. Or if you put them on a course of NSAIDs and then they'd had dyspepsia after being on NSAIDs, and then you stopped the NSAIDs and the dyspepsia went away, then you don't really need to do a scope. So that's explained. Nicely spotted. Thank you very much. What's that? No, that would be under the over 55 criteria. So there's recent, unexplained, and persistent. So even if somebody is 25 and they can't tell me a reason, it's unexplained why they've got dyspepsia. Actually, it doesn't really bother me that much. It's some PPI maybe the GP can deal with, but I'm not going to lose any sleep that they've got a cancer. If it's unexplained and they're over the age of 55, I've got to start looking for the reason.
So I'm just trying to work out what was the incorrect.
The incorrect was that I had said recent, persistent, and reoccurrent,
Yeah.
and I'd missed out unexplained.
Oh, you just missed it out.
Yeah, I missed it out. So that.
Most things are recent or persistent. Are you saying they either started recently or they've been going on for a long time?
Yeah, but then there's a difference between recent, as in what do you mean by recent? Recent in the last couple of months, I would say that's recent. If it's been going on for, somebody comes into my clinic and they've had indigestion now since the age of 25, and it's now been going on, persisting from 25 to 35 to 45 to 55, and they turn up on my clinic on their 55th birthday and they say, now I have persistent. Well, no, actually, this is just because your lower esophageal sphincter is duff. That's all it is, and you've got it. It doesn't mean that all of that ache that you've had all of that long just was a cancer that was causing that, and now you've passed the age of 55. These are nebulous, and it's difficult looking through the nice guidelines, because that's all they've said, recent, unexplained, or persistent. And I've tried to sit down and have a look around of what do they mean by, because I would say as well, what's recent and what's persistent. And I've tried to think of then going back and saying, well, what is it when I'm sitting in a clinic that I'm thinking about? And when I've spoken to the other consultants, what is it that they're thinking when they interpret those? And what they mean is, well, if they've had it all of their life, then that is persistent. But what they're saying is something that's changed. How do you tell that something has changed in somebody over the age of 55? And those are the words that they use to try and explain the fact that something has changed about the character of their dyspepsia. That it's not just down to medication, and it's not just down to down to how they're made. So it's,
So they'll make it clear.
yeah. What it will be is it'll be down to the red flag symptoms. Down to whether you can pick out a red flag symptoms from the description. And if anything, I'd say probably it's more about the serology that they're going to be interested in. And part two, I'd say part two would be more about interpreting that over 55 criteria. On part one questions, how it tends to go is that they ask you criteria in part one. In part two, they ask you to interpret something that's going on. So they'll have on the list which one of these things would mean that you would do an endoscopy, and they will list them: recurrent vomiting, recent onset of dyspepsia in somebody over the age of 55. So they'll actually use the words recent, unexplained, or persistent in the question itself. They won't expect you to interpret from somebody describing some symptoms. They will just have recent, unexplained, or persistent. Or they'll say somebody of 45 has recent, unexplained, and persistent dyspepsia, and then they'll ask you to decide what type of therapy that you're going to give them, so that you know that as a change over 55, the criteria are different. So it's, do you know actually the wording of the criteria in the question, and that's the wording is recent, unexplained, and persistent. Okay. So you can see why people moan a little bit about the Part 1 exam, because it seems like a nebulous amount of things that you need to know. But okay. Now, H. pylori, when it's sitting in your stomach, is going to cause a chronic inflammatory reaction within the stomach. You've got bacteria sitting in there that really shouldn't be there, that have worked their way into all of the nooks and crannies. And over a period of time, the stomach responds to that inflammation by either causing fibrosis in there or becoming irritated and inflammation happening there. And you can get the three complications within the stomach generally are chronic gastritis, atrophic gastritis. That means you have inflammation that's going on for so long that you get atrophy of all of that nice, complex architecture within the stomach wall lining. Atrophic gastritis. And achlorhydra. That means those gastric pits that the parietal cells that used to secrete acid and an intrinsic factor have become destroyed, and you stop producing acid within your stomach. So chronic gastritis, atrophic gastritis, and achlorhydra. And over a long period of time, inflammation anywhere is going to result in the increase in cancer rates, so gastric cancer. So the risk factors. H. pylori is a risk factor for gastric cancer. Interestingly, though, because your stomach is becoming inflamed and secreting less acid, there's less acid reflux occurring within the esophagus. And because there's less acid refluxing into the esophagus, it's actually associated with a decreased rates of esophageal cancer. So these are the associations, and they're all associated with an increased gastric cancer, but a decrease in esophageal cancer. So there are cancers that are associated with H. pylori. Gastric cancer is one, and the other one that you probably come along is malt cell lymphoma of the bowel. And what's nice about malt cell lymphoma is that you treat it. You treat the H. pylori and the malt cell lymphoma goes away. So I like asking questions about it. It's one of those nice, if you've had a cancer, that's a nice cancer to have had because you only require 2 antibiotics and a proton pump inhibitor. Amoxicillin, clarithromycin, and a PPI, take your pick. Those are all given twice daily. How long do you give it for? Well, there are 3 different treatment regimes, one for 7 days, one for 10 days, and one for 14 days. Don't ever give it for 14 days. There's no increased effectiveness of treating it for 14 days over 10 or 7 days, and they're just increased side effects. That was a big sigh. You can either treat it for 7 days and 10 days. You get about 95% of them with 7 days, and you get about 97% of them for 10 days. So is it really worth treating everybody for an extra 3 days? I don't know. You can make your own mind up. In this hospital, I think we only give people for a week. Other hospitals, they've given it for 10 days. You can make your mind up. Nice, there's 7 days. So I would give 7 days. I'm just going to make it to the end of this one, then we'll have 5 minutes leg stretching outside, and then we'll finish off the last topic. Then it's just consolidation in the end of the day. So I know it's a lot of information, and I'm getting sick of the sound of my voice, so I'm sure you are as well. But we're almost there, almost there. Gastric cancer. Risk factors for gastric cancer. This is a bit of a tenuous link. So blood group A. Nitros, amines. Pernicious anemia. Pernicious anemia, remember that? That's where you got anti-parietal cell antibodies. So you had an autoimmune reaction causing chronic inflammation by attacking parietal cells. So if you've got chronic inflammatory reaction causing irritation and inflammation, eventually you could get a cancer from it. You can also get pernicious anemia by having antibodies directed towards intrinsic factor. So there are two ways that you can get a pernicious anemia, either from the gastric cell, which produces H+, and intrinsic factor. So to that, or you can have it to that. Intrinsic factor binds with B12 and makes a complex that is then absorbed in the terminal ileum. There's lots of nice goodies that are absorbed in the terminal ileum, and we'll talk about that tomorrow. The other risk factors were H-Pylori. You can also put on your list all of the things that H-Pylori cause. Do you remember those? That was atrophic gastritis, achlorhydra, chronic gastritis. The other risk factors are all of the other things that we've talked about in gastroenterology so far, bar inflammatory bowel disease. So the things we talked about is non-hereditary, non-polyposis, getting tired, colorectal cancer, where you had your gastric cancer, your bowel cancer, and all of the womanly cancers. FAP is associated with gastric cancer as well. Celiac disease is associated with gastric cancer and esophageal cancer and a whole load of other things, which again we'll talk about tomorrow, but all of them bar inflammatory bowel disease cause an increase in your gastric cancer rates. So we've got a nice list of things now that we can identify: H. pylori and all of its goodies, hereditary non-polyposis colorectal cancer, FAP, and celiac disease. Turning over to the rear page, under H. pylori, in the H. pylori box, there's a flagellate. That means it's got an arm on that it waves. Flagellated means that you're being whipped with something, so there's a flagellate. And spiral-shaped, gram-negative, microaerophilic bacteria. Sometimes you use all or part of the name, but that may come up in a question, just so you know what type of bacteria it is. You know it's gram-negative now for sure. Let's do the question now. So you've got a woman in her late 30s. So in order to end up with a scope, what is she going to need to complain of? Yes, a red flag symptom, an alarm symptom, something that fits into that really nasty category. Recurrent vomiting, difficulty swallowing, epigastric mass, weight loss, or iron deficiency anemia. A woman of 30s attends a GP for an insurance medical. It comes to light that she has ongoing symptoms of dyspepsia. She is otherwise well, but complains that these symptoms have been present for at least 3 or 4 years. Are you worried that she has cancer? Not really. Although her job is stressful and her diet isn't as good as it should be, so that's probably caused by her job being stressful and her diet not being as good as she becomes increasingly concerned that her symptoms represent cancer rather than something benign. Which of the following statements is most accurate? Following NICE guidelines, endoscopy should be the first line investigation for this woman. No. A CLO test is usually performed as part of the test and treat strategy. Okay, that's wrong for 2 reasons. Firstly, CLO isn't, as you require an endoscopy as part of the test and treat. So we'll just go with one reason there. CLO test, and you have to do an endoscopy, take a sample, put it in that pregnancy test type thing, and you get either a positive or negative result from that. So CLO stands for Campylobacter-like organism. Alarm symptoms do not require immediate endoscopy if the patient is less than 55 years old. Is that true? No. That's why their alarm symptoms are alarming in anybody. If the symptoms were of recent onset and the patient was 46 years old, a 1-month trial of PPI without endoscopy would be first-line management. Yeah. So if they're less than 55 and they haven't got an alarm symptom, you can do either. Flick a coin, decide. These symptoms, in combination with a macrocytic anemia, would justify investigation via the rapid referral route for suspected cancer. No. Microscopic, yes. And you'll probably do some iron studies as well. But no. Take-home points. All those with dyspepsia and alarm symptoms, no matter what the age, require urgent endoscopy. Recent, unexplained or persistent symptoms in those over 55 require endoscopy. Medical management of dyspepsia involves either the test and treat or 1 month trial of a proton pump inhibitor like omeprazole or lansoprazole. Remember, PPIs tend to be enzyme inhibitors, and that increases the levels of some drugs. Now, it's become a popular panic point recently for people to worry about prescribing omeprazole and lansoprazole with clopidogrel. And if they're inhibitors, increasing the levels of some drug, why do they cause problems with clopidogrel? And the reason is this, is clopidogrel is a prodrug. So you start off with your prodrug, which is this with something attached to it, and then it has to be metabolized, and then it becomes active. And if you give somebody omeprazole, which are enzyme inhibitors, you inhibit this metabolic process. So the clopidogrel stays in its inactive form and doesn't end up becoming activated. And if it's not becoming activated, then the likelihood of thrombosing your stent when you're on clopidogrel and omeprazole is thought to be higher, actually, when they've done the studies. Not really. CAG-A and VAC-A genes increase the virulence of Helicobacter pylori, resulting in more severe disease. And that's part of the H-Pylori box in the rear of the page. Not only is it flagellate and spiral-shaped, that if you've got CAG-A or VAC-A, those are mutations that occur in it. It then becomes much nastier. Parietal cells are found in gastric pits and secrete acid and intrinsic factor, which we talked about a little bit before. Risk factors for gastric cancer were our A's, blood group A, nitrous A means pernicious anemia, and then all of the things that fit under gastroenterology, inflammatory bowel disease, which was H. pylori, celiac disease, HNPCC, and familial adenomatous polyposis coli. So we're just going to stop for 5 minutes, just to have a bit of a walk around and a breather, and then we'll come back to it in 5, and we'll give the bell a quick ring. Otherwise, we'll really be crawling on that last one. Any questions just now? Okay.
Can I just ask what
Yes.
nitrous amine is?
Nitrous amines are found in processed plastic products. They can also be found in certain dyes, not like alanine dye, which is associated with bladder cancer. Also in some oils. Oils that have been burnt are found in. So there's a lot of things that are found in. Yeah. They will just say nitrous amines. They won't give you a product and expect you to know, oh, that's got nitrous amines in it. No.